Good morning, ladies and gentlemen. Welcome back to EuroPCR. It's been 3 years, and really everyone here is, with the PCR is really happy to see all of you. This place is the crowd, and it attests to the fact that you're back and forth. I'm seeing friends that I've not seen in the last 3 years, and for this session, some of them should actually be here, giving their input on how to do a DK crush. So it's good to be back, and I just want to introduce the panelists.
Sound in my ear.
The panelist, the moderator is Dr. Amin from Malaysia, from National Heart Institution of Malaysia. And then we have discussants. We have on site with us Dr. Chen, Flensted Lassen from Denmark. And we have got two of our eminent colleagues. First is Professor Chen Shao-Liang, all the way from China. He's, as you know it, the master in doing a DK crush. And the other one is Dr. Ajay Kirtane from the States. So unfortunately, they could not be with us. Otherwise, they would be very happy to be with us. And I also would like to introduce our chat master, Dr. Kumara Gurupparan from the National Heart Institute of Malaysia. And the session that we're going to have and to be discussed today is on DK crush, the optimal two-stent strategy, bifurcation strategy for left main PCI. So essentially, that is the the topic that we're going to discuss today, and this is a tools and techniques session. So we're going to discuss in detail about the technique of performing a DK crush. I have no potential conflict of interest. I mean, perhaps you'd like to remind our audience, both virtual and on-site, with regards to what and how they can participate and interact with our session.
Thank you, Rosli. A very warm welcome to all of you. It's nice to be here again after 3 years. Now, we have a chat master in Malaysia, which is Dr. Kumara, that will take questions if you go to the chat box, and he will try and reply online as well. We also would like to entertain questions from the floor. You can pull up a mic and ask questions. And if there's anything interesting on the chat questions, we will also pose it to the panelists, and we will get moving along in those lines. I think it's going to be a very interesting session. Back to you, Rosli.
Right. Thanks very much, Amin. So let's go on, and we have the session objectives, which is firstly is to learn how to optimally treat a calcified left main stem lesion. And secondly, to understand how imaging can help in strategizing your procedure, especially in bifurcation lesions, in this case, left main. Number 3 is to be familiar on how to perform bifurcation PCI of left main, specifically with the DK crush technique. And last, the objective is to discuss the important factors that you may want to consider when you choose a stent for the left main. So without further ado, I would like to just play the recorded case from the National Heart Institute of Kuala Lumpur. The operators are Dr. Saiful Azmi and Dr. Kumara, and the IVERS is going to be reported by Dr. Lee. All right, let's play this. The first is for case introduction.
Happy to be involved with the PCR for this year. With me is Dr. Kumara, interventional cardiologist, who will show you a case later on. And with me, scrub nurse Halim, Azwin, my cardioangiographer Joanne, and cardiovascular technician Amin. So I will ask Dr. Kumara to present the case.
A very good day, everyone. Thank you, Dr. Shaiful. So we have here a 67-year-old male who presented with chest pain on exertion, typical of angina for the last 1 month, relieved by rest and sublingual GTN. He's not known to have any medical illness, and he doesn't smoke. So he had presented to a district hospital where a diagnostic coronary angiogram was done and referred to us for further management. He's got a normal renal profile. Total cholesterols and LDLs are elevated. He's not on any medication. Normal HbA1c, and his resting ECG showed sinus rhythm with mild ST segment depression on the anterior leads. So we've just got the diagnostic angiogram done. Dr. Shaiful, pass it back to you.
Okay, I think you can see the angiogram quite well. At the moment, we are having a EBU catheter, 7 French, yeah? And you can see the images of the contrast going down at the left main the LAD and circumflex, and it is a 111 lesion. And if you see from the epicranial view, here you can also appreciate another lesion, which is at the proximal LAD at the diagonal bifurcation, which is also a 111 lesion. So here we're dealing with two bifurcation lesions, and we'll discuss further on the strategy that we're going to have to go to with.
Okay, so that's the history and also angiographic findings. Let's just start off with the discussion with how you would like to treat this case. I just want to ask Professor Lassen, when you look at the angiogram, in terms of treatment, how are you going to treat the LED and the left main? So because there's two bifurcation lesions, are you going to treat it as one entity, means to say that you're going to lose one long stent, or you are going to treat them separately?
Well, first of all, it's an excellent choice of a case because there's so many things to discuss and there's so many options. I think the LAD-D1 actually is basically a 90-degree takeoff. So that's actually a pretty easy, straightforward strategy to put on that. But the case is that we need maybe to treat that first and then go for the left main afterwards. And that actually always is a bit scary somehow. So you actually need to have a kind of a bailout procedure for the left main before you start on the LAD-D1, because maybe you need it very, very quickly. So I would definitely use two wires, one in the circumflex and one in the LAD. Yep. And I will also use 3 wires because I would like to have a wire in the D1 as well. So that would be actually my preferred start of that case. And then depending on which technique I will use, I would actually use different approaches. In my opinion, I always try to do a procedure as simple as possible, but not too simple, but also as safe as possible. And that means that one of the safest procedure we have is actually the DK cross, but it's not the simplest procedure. The beauty of the DK cross is that you will actually have clear access to all the vessels all during the procedure, which makes it a safe thing and a safe procedure. So that's actually talks for it. The other thing is that you will never be able to perform it simple. You will always end with a total jailed bifurcation with 2 stents, which actually jeopardize the biology and the physiology afterwards, and actually also have basically a bit more risk for the long run. This was not a young person. So right. I would actually go provisional for the LAD-D1, and then I'll go back and discuss what to do for the left main. But I would go provisional both places, but I think there is discussion for DK cross in the left main.
All right. Thank you. Ajay, do you have the same thoughts, which is to treat them separately, perhaps treat the LED first and then subsequently treat the left main? Is that something that you would like to consider? Ajay, can you hear us? Okay, if Ajay can't hear us, so is Shao-Liang, can you hear the discussion?
Your discussion very clear.
Yes, yes. Do you think you do separately as 2 stents? Treat the 2 bifurcations differently?
Yeah, I think I should comment before me, Ajay.
Oh, can you hear me now or no?
Yes, I can hear you now.
Okay, great. I think all the points that were made were really very valid, and I think the key educational point that was made, which is so important and simple, was basically that sometimes the safest thing is not the simplest thing. That is really important because too often we see people cutting corners, and then that sacrifices the safety of the case. And so to me, I think ideally this could be done with 1 long stent from the left main extending to the LAD. But the challenge with that approach is that you have to deal with that LAD diagonal bifurcation first. And so in many respects, to do it in a sequential modular way, deal with the LED diagonal bifurcation, then deal with the left main. Yeah, you may have to use an additional stent, but I think that that's the right way to do it. And I would agree with all the comments made previously.
All right. Shao-Liang, I just want to inquire from you. What do you think is the role of imaging here? Do you think it's a necessity to do imaging, especially with regards to assessing the circumflex? Because from the angiogram, it doesn't really look that bad.
Yeah, actually, thank you, Dr. Rosli, to invite me to join your session. Firstly, I think angiographically, it looks like not left dominant because we could not see the right coronary artery angiography. So I think a provisional staining technique will be good for LAD D1. For distal left main bifurcation lesion, if there is no any sign of vulnerable plaque at the ostium circumflex, because the lesion in circumflex is pretty short. So from multiple views, it looks like only 5 mm in circumflex. Also, I will choose provisional for this left main. I'm sorry, but to be honest, this is a very, very excellent case.
All right. So, are there any questions from the chat group?
I think there's a question, two questions. I think the first one was already dealt with. That means you do the LAD D1 first before going to the left main. I think that was already answered. Now there's another question. Anyone would do a simple crossover stenting for both lesions? That is a question.
Yeah. Lassen?
Well, yeah, I think that would be my approach. Well, I would not be so scared of the D1 because it's not a very large vessel, and we have to remember that really to define a significant side branch, it should supply more than 10% of the myocardium, and you could be in doubt if that's the case here.
Yeah.
So I would actually just go across it, and if it closes and it doesn't cause pain, I would maybe just leave it.
Yeah. I mean, Shao-Liang also thought of the same, which is just a simple crossover and then decide subsequently.
Yeah.
Anyone from the audience, before we move on and see what this, imaging, I think is important because they saw calcification in the left main. There's some calcification, sometimes you have difficulty in terms of assessing. And I think it's also important to assess the circumflex at the same time, besides knowing all the other things, which is the sizing of the left main, and then the device and the strategy that you're going to take subsequently. Anyone? Comments? Questions?
One other quick comment is that if someone did entertain stenting across both bifurcations with a single stent, the issue of size mismatch from the left main, which is going to be very big, to that mid-LAD, you need to have the stent with the right expansion capacity to be able to address that. So just know that in advance if that's the strategy you pick.
Yeah. Well, from what I seem to look in the audience, it seems that they're probably in agreement that it's probably easier and safer to treat two bifurcations separately and then make it easier, and the choice of technique will be much safer. So that's how I view if I read all of you well. Okay, so let's go about, and obviously they felt that imaging was important. This is by Dr. Lee. Can we have the imaging, please? Can you have slides on?
Big diagonal at the distal LAD.
I will restart that. All right.
Hello, everyone in Paris. So we have an IVUS, and we're recording from the distal part of the LAD, just close to that big diagonal at the distal LAD. You can see it comes in here. Right here, we can see that the vessel is almost a 3-0 vessel, and there's minimal plaque at the distal part. It's quite clean. So I think this area is suitable for distal stent landing. And here you can see a bit of calcified plaque comes in, and it continues to grow almost circumferentially. Flush. And yeah, you can see that this part, there is calcium as well. But fortunately, the calcium is not entirely circumferential, at most probably 3 quadrants. As we progress more proximally, we see a large, almost area of aneurysm. It's actually what we call positive remodeling of the vessel. And more proximally here, we can see the circ entering, and then that's very close to the left main. And the left main is a large vessel with severe disease at its distal segment. And here is the guide. All right, and so now we have the IVUS in the circumflex. So we're starting somewhere in the mid-circumflex. You can see the IVUS, the vessel is quite clean. Couple of branches coming in from the sides. And just estimating here is about 3 over. And the plaque starts to build up around here at the ostial circ. And you can see the wire from the left main coming in at 3 o'clock, from the LED coming in at 3 o'clock and into the left main and into the guide. So if we just look at this IVUS reading, I think the point of interest is the ostial circumflex. And closing on the ostial circumflex, actually it does look diseased here. And we can calculate the ml. I think that's the biggest question in this case. Is the ostial circumflex significant? So this right here is the ostial circumflex. Putting in the mean area of the lumen, it's about 4.45. I think it's borderline significant, but if the patient has symptoms, probably worth treating. The plaque burden here is also quite heavy.
Okay.
Yeah, plaque burden 64%.
Okay, so that's the IVUS.
Hello everyone.
That's the IVUS, and we'll discuss something about following the IVUS findings now. So we have now a much complete picture about the angiogram and also the IVUS findings, and we just want to see how we're going to treat this.
Rosli,
yes.
just 2 questions from the chat, right? Assessment of calcified left main, what is your preferred modality, IVUS or OCT? I think that's quite clear. Maybe you can answer that. And do you use IVUS mandatorily for all left main, or there's some cases that you might not want to use IVUS?
All right.
One more question, when setting the distal left main, how do you choose where to put your stent, left main LED or left main circumflex, when you don't have IVUS?
Okay.
So, those are
so
the
we'll keep the last question first. So essentially, let's go by IVUS. A quick question. Lassen, necessity or no?
Well, the more you know of a lesion, the better. So yeah, of course, it would be very good to use the IVUS. To actually take the discussion on the significance, in this case, is not really relevant because we know that at least the combination of those 2 lesions are significant. But to measure actually the sizes of the vessel where they are healthy is extremely important. And I totally agree with Kirtane, who told us that there is a huge step up in diameter from the LAD to the left main. And we need to realize that when we are treating bifurcations, and especially the left main, we have a tubular device, and we actually manipulate that device to be tapered. And that means that actually we put a lot of technical pressure on the stent, on the polymer, on the struts, and on everything to make it fit. So it's very, very good to have a precise measurement of the distal diameter for that stent and the proximal diameter. And then choose the stent maybe too big for the distal and then underdilated distally, so it fits proximally. So we have another decision to make, and there's IVUS or OCT, for instance, a very, very good also add-on instrument to make these decisions.
So you would do for every patient?
No, I won't do for every patient, but it's because of me. In the learning period, I actually use IVUS very, very much. So with the OCT. Then actually I tend to learn how to do it. So now I do it when I'm in doubt. And I'm actually often in doubt, so I use it.
Okay. Shao-Liang, your thoughts on IVUS for left main?
Thank you, Dr. Rosli. I think one similar finding from IVUS to angiography is the less severely diseased than the osteotomy of circumflex. But one very important finding from IVUS is that the calcified plaque in the distal left main is just opposite to the osteotomy of circumflex. This is a very important finding from recent studies. So if the calcified or fibrous plaque at the distal left main opposite to the osteocircumflex, which easily to get the very severe shift of crine by ballooning or after standing main vessel. So from the IVUS finding, I will change my idea to use DK quash.
All right. Okay, that's important point. Thank you very much. Ajay, again about the IVUS use in left main, you do it for every case of yours?
Yeah, I would. I mean, I think you have to do imaging because it will change what you do. It'll change your sizes. It'll change your bifurcation strategy. OCT or IVUS, either are fine. The OCT is a challenge for the ostium, but in this case, the ostium tends to not be involved. So I would certainly do imaging, and it'll change what I do. So that's why we do it.
And we do have some data with regards to outcome, isn't it? With Nadim, yes.
I think regarding this imaging issue and whether it's mandatory or not, initially I think it's very important that everyone who is doing bifurcation in left main should know imaging. But as you go along in a country like Pakistan, where there are hundreds of cath labs but IVUSs are far and few, the problem happens that if you tend to shy away in labs where there are complex cases in non-STEMI and STEMI when you are 24 and you've got a large diagonal and you are not trained in DK crush and left main because of lack of imaging, then you shy away and just put a provisional stent. So my view would be that everyone should be trained in imaging and they should be comfortable in imaging, but once they go into their private practices and in far-flung areas, they should be trained enough to have their eyes as IVUSs. And initially, when I was doing left main 20 years back, I used to do IVUSs, but then eventually now I hardly ever use IVUS for left main or DK crush. And I think that should be the strategy because cost and remoteness of areas, IVUS are not available in developing countries everywhere and it adds to the cost. So I think the technique should be sophisticated enough and they should be trained enough to know what is the size of the left main in that particular case, what is the type of the calcium, whether it's medial, intimal or nutaceous, and the tools should be there to bail yourself out in a complication rate rather than doing IVUSs in every single case of DK crush or left main.
Yeah, thanks for your opinion. So again, practically I suppose you have to be aware of the limitations of your centers. But obviously, one needs to make sure that one do the procedure very well, especially in left main, because it's sometimes unforgiving in the short and also in the longer term. So I think that's good because that sets the stage. Lassen, do you think the concern that they had was initially was the calcium was a lot in the left main. How are you going to prepare this lesion?
Well, actually, I think for this lesion, I would just balloon it and remember the old trick of avoid having air in the balloons and then just see how are the contours of the balloon when you actually increases the pressure, because that gives you a lot of information of that calcium. It was not a total circular calcium, so it might be easy to push it away. But I actually do agree with the comment of Shao-Liang Chen that there was more calcium in the ostium of the circumflex that I anticipated from the angiogram. And that made some of the procedures a bit more difficult. I may not choose to jump directly to DK cross, but I may consider actually to be a bit more aggressive in my vessel preparation.
All right.
Yeah, so, and of course, if my balloons opens, it's okay. Otherwise, I will actually just escalate for atherectomy or rotablation or...
Let me just go back to, now it appears that at least 2 out of 3, I haven't asked Ajay yet, that they're going for two-stent strategy, right? So what are the factors that you will consider if you want to choose one strategy or the other for a two-stent strategy? What are the things that you look at? First.
First of all, I need to declare my conflicts of interest because I was one of the the authors of the EBC main, which actually advocate the provisional strategy. But I also want to stress one thing that is not that much discussed, because when we talk about provisional strategy, everybody thinks it's one stent, and if they need two stents, it's a bailout. But that's not true. Provisional strategy could also be an upfront two-stent strategy where you decide to use two-stent but go provisional to reach the goal. And that's important. So if I would go for two-stent in this case, I would actually stent the circumflex first, because then I will stent opposite, the reversed provisional, and may be able to only use one stent still if I have a nice result in the LAD. So, and if I doesn't, I will actually escalate to In this case, because of the angle and the discrepancy in diameter, I will probably go for a culotte. But depends on how the procedure actually develops.
All right. And you choose a culotte because?
Well, I will choose a culotte when I have actually successfully rewired the other vessel, because it depends where I actually end up rewiring it, because the geometry of the opening to the other vessel actually defines if I will go for a T or a culotte or a tap.
So you're saying that the first important point is, if two stents, whether it's provisional or otherwise, would be the angulation of the bifurcation. Is that what you're saying?
Yeah, well, yeah, that would be one of the perceptions in it. Yeah. But actually, you can't really predict how a procedure ends. So you have to make it stepwise and then be able to change your decision. As Dr. Kirtane said, you learn when you use imaging, and that may change your strategy.
All right.
Because and one of the beauties of the DK cross is actually those 10 steps in the procedure. You start and you end, and it's over.
Yeah.
Final. No more discussion, no more decisions.
Yeah.
If you go provisional, you actually have to stepwise make a new decision for every step.
All right. Okay, Ajay, going back to the classical choice of a two-stent strategy. So whether you use a culotte, a T, or DK crush, people have been saying about the angulation of the bifurcation. How does it help you to choose if the angle is more than 70 degrees or less than 70 degrees? So how do you choose one two-stent strategy over the other?
Yeah, I think all of those things are important. It's angle, it's size mismatch too, right? In this case, the circ is relatively small. And so if you were going to consider a traditional culotte type of stent, you're potentially going to have a mismatch between the left main and the size of the circumflex. So that plus the angle are what, to me, lead a lot to it. The other thing is the safety of the procedure and how you're going to do it. If you feel like you're going to have a very difficult time rewiring, then the culotte is probably not the best strategy, because you're going to have to cross through the side. Whereas with the DK crush, again, you set the side branch, it's safe, you deal with the main branch later, and then you can be very reproducible in your results. So for a variety of reasons here, the main choice for me is there significant disease at the ostium of the circumflex? The angiogram was a little bit ambiguous. The IVUS shows you, yes, it was. Once that's the case, in this type of case, for me, I'm going DK crush.
All right, okay. So mismatch, bifurcation angle, and those are the important issues for you to choose one or the other. So let's run through the video and see how they decided on the strategy and the case execution.
Really 111. So it's a matter of choice whether how do we want to treat the first bifurcation, which is the LAD diagonal, and the second bifurcation. But for the purpose of teaching, we are going to do a DK crush on the left main LAD and circumflex bifurcation. Okay, welcome back. Now we are having two wires, one which is run through floppy in the LAD, and a Sion blue in the diagonal, the second diagonal. And we have used a score flags 30 by 15, and we have gone up to 12 and 14 atmosphere pre-dilating of the proximal LAD. If you remember, there's some calcium seen on the IVUS, and now I think you can appreciate that the balloon has effectively pushed the calcium away. Okay, this is the result post-ballooning, pre-dilating. The flow looks good in both the LAD and diagonal. And now we are inserting the stent. This is Resolute Onyx 30 by 22. Our intention is to cover just at the distal part of the aneurysm, and the distal part of the stenosis that we're going to cover is just before the bend at the mid-LAD. So this is the placement in two views, and we are now inflating this stent at nominal pressure, which is at 12 atmosphere. This is the result of the stenting, and then subsequently we post-dilated the distal segment with a 30 by 12 millimeter balloon NC, and a 3.5 by 12 as well at the more proximal part of the stent. And we'll show you this is the result of the intervention that we did for the first bifurcation, which is the proximal LED and diagonal. I think you can appreciate that the flow looks good in both the LED and the diagonal. However, there's a slight pinching of the diagonal, which I think is about 2.0. But the intention is just to keep the vessel open with the wire as a protection. And I think we have reached what we wanted to do, and therefore we'll move on to the left main bifurcation now. Thank you.
So we have now wired the circumflex. We've got the same wire from the diagonal down the circumflex, and we are pre-dilating the huge chunky lesion in the left main to the ostial LED. This is a 3O Scoreflex that we had used earlier. It opened quite well, and as you can see, we are dealing with a short lesion here from the left main to the proximal ostial LED. The balloon opened up quite well, and we managed to establish good flow down the LED. And this is basically measuring the length using the balloon from the ostial left main to the intended zone of landing. And we pre-dilated the ostial circumflex with the same Scoreflex 3O at high pressures at about 16 atmospheres. We have got good, we have good luminal gain there from the balloon dilation. This is the delivery of the first stent to the side branch. Here, in this case, the circumflex. This is the Onyx 3O 12 millimeter stent, which was delivered quite easily. And then the crushing balloon. This is a 4012 NC, sized 1:1 ratio, based on the IVUS findings. And then we have to place the stent at the ostium of the circumflex with about 2 to 3 struts jutting into the left main. So we checked this in two views. That was the caudal view, and this is the spider view. Here the jutting was not adequate, so we pulled it back a little bit. And here we have got good amount of side branch ostial coverage. And then the stent was deployed at nominal pressure. And then we did a pullback high pressure dilatation with the stent balloon. In this case, the Onyx has got a non-compliant balloon, so we use this for high pressure dilatation. And then proximal side branch optimization using a 3O NC at high pressures. This was at 18 to 20 atmospheres. Here we are using stent boost to ensure that we have got good coverage of the ostium. So this is at 20 atmospheres. So once that has been done, we just pull back the LED crushing balloon. This is a 4O NC at 12 to 14 atmospheres. We did a stent boost to check on whether we have done a good crush. We went up high pressure again at about 16 to 18 atmospheres. And then the first proximal optimization, we're using a pot balloon. This is a 4.5 8 millimeter balloon, and this was inflated at 14 to 16 atmospheres. So we ensure that we have got good stent crushing with the pot balloon. So this is the first pot. So with the decay crush, there are 3 pots. This will be the first pot. This is a check after we have stented and crushed the stent into the circumflex. Okay, then we rewired the stent, the crushed stent, aiming for the proximal stent strut. Dr. Shaiful, I think there are a few ways we can ensure that we have got the proximal edge. One will be using imaging, IVUS or even OCT. In this case, we decided to use stent boost. So this is a wire with the balloon on the wire. So from the stent boost, we can appreciate that we have actually got the proximal to mid stent strut, right? And then post-dilated, opened up the struts at high pressure. Then this is the first kiss using a 4O NC in the LED left main and a 3O 12 NC in the left main circumflex. So side branch post-dilatation at high pressures, and then the kissing. So the first kiss, 4O and 3O at 12 nominal atmospheres. So once you ensure you have got a good case, then delivery of the left main LED stent. This is a 4.0 by 18 resolute onyx, 4.0 by 22 resolute onyx stent. We had a bit of a difficulty here, Dr. Shaiful, determining the length, because we did not want to jut too much into the aneurysm, and at the same time ensuring that we cover the ostium of the left main.
And if you may, based on the IVUS, the length was 18 mm, slightly more than that, and we do not think that 18 mm will be good, so we had to use a 22 mm just to make sure that we cover the ostial of the LED as well as the ostial of the left main.
Yeah. So we, given the fact that we have done a good vessel preparation, so I think delivery of this 4.0/22 stent was quite uneventful. It was smooth, so we managed to get it down. So the idea was to cover the ostium of the left main. So this was the caudal shot. We checked at the LAO 2020 view, ensuring that we get the ostium. Then after confirming the position of the stent was deployed, and this path shows that we managed to get the ostium of the left main. So after the main branch stent deployment, this is the second pot, using the same 4.5 NC balloon. This is at slightly high pressure, as 16 to 18 atmospheres. We ensure using stent boost that we are at the POC, not too much into the main branch, and adequate to cover the POC right up to the ostium of the left main. So 2 inflations and 1 right up to the ostium, flaring it. As you can see, we've got good balloon inflation. So now comes the step where we'll have to rewire the jailed circumflex wire. And when we pulled the wire back, we realized there was a bit of a resistance. So that's a good sign that we have got good main branch stent deployment, that we have got good stent apposition. Some people like to use a third wire, but in our usual practice, we just use the same wire, I believe, in the memory of the curve. So it makes the re-entry a bit easy, recrossing. So because we have done a good pot, we are sure that we are within the stent struts. We will not go behind the stent struts. And it's good practice to actually go into the main branch, pull back, and then aim for either the mid or the proximal stent struts to rewire into the side branch. And then this is the 4.0 NC in the left main LED parked there. We had some difficulty using a winged balloon, a 3.0 NC for the second kiss. So we decided to use a new balloon. Even the new balloon had a bit of difficulty because of the recrossing. So we used the balloon anchor technique. We inflated the 4.0 NC at low pressures at the initial stent in the mid LED. And then with that, with gentle pressure, we managed to get the 3.0 NC down from the left main into the circumflex. So this was a high pressure dilatation of the ostium of the side branch, the circumflex, at 18 to 20 atmospheres. And then the second kiss in the DK crush, double kissing crush, this is at 12 atmospheres, 4.0 NC in the left main LED and a 3.0 NC in the left main circ. And then the final pot, the third pot, again ensuring it's able to go down the main vessel without any difficulty. Using stent boost to ensure that we are at the POC. Then at high pressure, 16 to 18 atmospheres, at high pressures, right up to the ostium, and these were the final results. So based on the IVUS, I think we will now proceed with the IVUS to see how we have done and whether there's any need for further post-dilatation. Thank you.
So guys, IVUS after the completion of procedure, we started distal to the stent. So the first stent landed nicely. There was no distal stentish dissections. And here you can see the stent is well open, well expanded. And of course, it abuts some fibrocalcific plaque from 3 to 6 o'clock, but nothing much to worry about because the calculated size is good. Now, as we come close to the end of the first stent, we are in that area of positive remodeling. There's a short gap before we start the ostium of the next stent, so probably a very short gap. And this stent, once again, is also well opposed And you can see the circ wire coming in, and so we have a lot of signal in the top part. That's the crush part of the circumflex stent, and here we are in the left main, and the left main stent goes to the ostium and is well opposed. There are no malopposed struts in the ostium of the left main. All right, so we're starting off in the normal segment of the circ vessel. And you can see here the vessel is quite healthy, a thin layer. Okay, nice. The stent comes in and it's very nice, 1-to-1 with the circumflex vessel, landed on a healthy segment with no distal stenix dissections. Here's the ostium circ, and it joins into the left main LAD from about 5 o'clock. And here we are in the left main, and the left main stent once again feels very well expanded, just nicely landed at the ostium of the left main. So I think the thing we need to look at is clearly the mean stented area of the ostium circumflex. So we've calculated here. It's about 6.5 millimeters square.
That's the discussion. So I think we'd like to spend, hopefully in about 12 minutes, we can go step by step of the decay crush. We'll answer some of the questions. So one of the questions from the chat master was saying that if you actually want to do a decay crush, is there a point that we stent into the circumflex first rather than the LED? Shao-Liang, would you like to take up that question?
Okay.
Stenting in the circ first rather than, crush the LED and stenting into the circ.
Pardon Dr. Rosli, I cannot hear you very clearly.
All right.
Can you repeat it again?
Usually we tend to stent the crush into the side branch first, right? And is there a situation that you actually crush the LED and then stent from left main stem to the circ?
Yeah, actually, for distal left main bifurcation lesion, LAD should be considered as the main vessel. For most cases, the only exception is that if a patient had a history of anterior valve myocardial infarction, we could use the circumflex as the main vessel. Thank you.
All right. So mainly it's, but Ajay, would you sometimes crush the, LED and?
No, not in a case like this. I mean, typically you crush the side branch stent first and then do the main afterwards. There were also some pretty interesting comments in the chat about when you pull the wire and other things, just some few teaching points that I'll make. I do tend to pull the wire before crushing the stent because I don't want the wire to be trapped. You already know where the vessel is because it's stented, so therefore you don't need to do that. The other thing I do before I do the crush is I do take an injection to make sure there's no distal edge dissection along the side branch, because if there's a dissection in the circ and then you crush the stent, it's going to be much harder to treat that. You'd want to treat that distal edge dissection before crushing the stent. So those are the 2 points. I think the anchor technique was nicely illustrated in this case. It's really, really useful. As much as we try to think this is a simple technique, oftentimes there are struggles getting wires, getting balloons back in. And then the final comment I'll make is why DK versus a conventional crush? And the entire reason behind it, besides the geometry, is from a practical standpoint, rewiring back through that crushed stent is much easier if you've already done the first kiss than if you've not. And that's really, I think, why Shao-Liang and others pioneered this approach to approaching bifurcation lesions, was because we knew that if you did a conventional crush, the likelihood that you could achieve a final kissing balloon inflation was significantly less than if you did that initial kiss in the beginning.
All right. The question that I have is that if you look step by step, you have already vessel prepared. How much of stent struts should you jut into the main vessel if you were to crush the first stent? Is it going to be a mini crush, very little, or to be on the safe side, you just pull back 2 or 3 mm, like what was done by Saiful and Kumara just now? Lance, sorry, Lassen. It's difficult to ask.
Well, yeah. Again, it's an excellent question and an excellent discussion. I think most of us perceive that we have 3 tubes, vessels, meeting in a bifurcation. But this is actually not the case. The case is that we have a pentagon in the middle, a 3-dimensional pentagon, the polygon of confluence, which is basically have another diameter than all the vessels. And that pentagon of confluence or polygon of confluence is actually extremely difficult to scaffold. So if you like to have the perception that you'll go for the takeoff of the ostium, there is no takeoff of the ostium. There is a slightly harmonic increasing over the confluence of the pentagon of confluence. And that means that you need to have a bit of a stent struts up to be sure to cover the ostium. The other problem is that when you cross the stent, then you cross the stent strut from the proximal end of the stent, and you'll have a curve of more or less strut going down into the side branch, which makes a gap on the floor of the takeoff of the circumflex. So if you actually rewire too low the next time and do the kissing, then you'll have a non-stented area in the DK cross technique. So now I'll answer your question. Yes, some stent struts up in the left main, cross it, and then aim for a more proximal or mid recross to be able to cover the floor of the circumflex.
Yeah.
Yeah.
All right. So essentially, if that were to be said, again, you don't want to have too much of stent struts into the left main, but you don't want to be missing the ostium. I think that's very important. Can we have the slides on, please? That's the slides.
Okay, Rosli, can I just, there's some questions on the chat in terms of data. I think you're going to explain that.
Yeah,
DK
we'll probably go by data.
And I think there's a lot of tips and techniques. I think that one Dr. Kumara can sort of reply on their behalf. I don't think we have time to go into that.
Right, okay. So my question is, you're talking about 3 pots, right? The first pot. So is the first pot essential, Shao-Liang, in your practice? Because we have, you crush, and then there's people who are saying that they should have the first pot, and then you crush the stent starts better. Do you think that's an important step to you, Shao-Liang?
Yeah, actually, it's very, very important. Because, first part is not only first part. It's to completely crush the side stent. So I think this is a very excellent case should be the SOP of DK crush technique, which was done even much better than my case. So sometimes, for this case, I also have additional 2 or 3 comments. Usually, before stenting main vessel, we need to remove the side wire. Otherwise, if we keep the side wire in its place before stenting main vessel, so after retrieving the side branch wire, don't forget to do one more pot technique. The reason is that after stenting main vessel and then remove the side wire, so which will cause the distortion of main vessel stent. So from this case, you can see after stenting main vessel, there was a little bit of resistance to put the 3/0 NC balloon into the stent flex. But I think it's a small problem. Thank you.
All right, so that's important. The first part has been mentioned. All right. So the other thing that is always discussed is, do you go to proximal or you go to the mid or distal wire? Yes, Lassen, before.
Well, sorry.
Yep.
There's one more comment on the 3-pot in the DK cross, because we have to remember that it's very easy to do a DK cross and make it actually be open, but it's difficult to make a DK cross have a tapered stent in the main vessel. And that means that there is, after the first crossing, you actually cross from the distal part to the proximal part and cross the stent. But the proximal part has a larger diameter, so that needs a pot which is not going down in the distal, but is in the proximal part, because then you shape the stent to accommodate the next stent to be tapered.
Yes.
So that's also a really important thing, which is stressed very well by Shao-Liang, but you have to have this 3-dimensional orientation that is not a tube, it's a tapering.
Yep, I think that's very important. So With regards wiring, Ajay, do you want, yes, Ajay, you want to say something about the...
No, Rosli, I was just going to say, are you going to show those visible heart videos that actually look at it? Because I think that the best illustration of why you need to do a pot is shown in those videos, because you basically run the risk of getting behind the stent struts if you don't do the pot. And I don't know if you were going to show those, but if not, we can make them available to the attendees afterwards, because they really nicely illustrate these concepts.
Yeah, actually the slides are based on that, but we can't have the moving images shown on the screen right now. So I just cut and paste and just to emphasize certain points. And we're actually using the visible heart images to try to illustrate that. All right, so I think Lassen actually, Professor Lassen actually explained why you should be thinking about ensuring that the stent struts is expanded. And the first wiring is usually either the proximal or mid. Once again, not to miss the stent opposed towards the floor of the circumflex. I think that's the reason why. And essentially, in the end, you want to ensure that the stents are well expanded in all the areas of the vessel. So that's one. Anything else with regards to that? Kissing balloon has been mentioned. I think appropriate kissing balloon and low pressure. I think you don't want to cause any dissection, especially to the proximal and okay, still. So the stent was stented until the ostial left mean. Is it important to stent until the ostial left mean all the time, Shao-Liang?
Yeah. Actually, Dr. Rosli, I have one more comment about the kissing balloon inflation. For both first and second kissing balloon inflation, we should keep the overlapping length of two balloons in the main vessel as short as possible. This is very important to reshape the crown, to reshape the POC area. Because we all know POC area is irregular. So if two balloons overlapping too much in the main vessel, both balloons will stretch the main vessel and the side branch, which is not useful for POC area reshaping. Thank you.
Okay. When do we high pressure the side branch? Is it at folding the stent deployment for the side branch, or is it at the point where we're going to do the last kissing? When do you
I'm sorry. Actually, before any kissing balloon inflation, we have to do sequential inflation starting from side branch to main vessel. Usually, both balloons are inflated at a minimum 16 atmosphere. We have done a lot of bench tests to identify the importance of sequential balloon inflation at high pressure. For example, when we finish the first ballooning insert inside branch, and then deflating the side branch balloon and inflating the main vessel balloon. Finally, we need to simultaneously inflate the two balloons at equal pressure.
All right.
Thank you.
And do you do this every time? You mean say every time before you pot, especially the second and third pot?
It's right before the kiss.
Right. So for both.
Basically.
Yeah.
Yeah.
All right.
But especially that side branch, I mean, when you do a kiss, before you kiss, most people just go and do the kiss. You want to dilate the side branch at high, like 18 atmospheres with a non-compliant balloon, then the main branch, and then the two together is very, very important.
Yeah.
The one other question that came up in the chat was, how about the wiring technique? And again, from these visible heart videos, what you'll see is that if you spin the wire too much, you'll get wrap and all this kinds of stuff that goes on with the wire. And so you take the torquer, if you're not going to have a torquer, and it's very gentle back and forth to try to get that thing in, because otherwise it really is a problem for you. That's a very important technical point to make.
All right. And some people would actually also do use a wire which is very sleek so that it can pass through easily. So you may want to use a polymer jacketed wire in case you have some issues. But you got to be very careful that you're not outside the stent struts. I think all of you would agree with it. So are there any other questions, that is important to anyone before we just have about 2 minutes to look at the data, and Shao-Liang will, Shao-Liang, would you like to share with us some data that says in your mind that the DK crush is a superior two-stent strategy?
Thank you. Actually, I lost my slides. I only introduced some data orally. Actually, you know, we have done a lot of randomized study to compare DK quash with different kinds of standing technique, including provisional. So basically, I think the key steps of DK quash is short protrusion of side stand, completed quash, and rewiring from the proximal to middle cell, and kissing balloon inflation at very high quality. I think these are key steps.
Yeah, especially I think that the side branch is very important. Lassen, I know that I'm not going to put in a spot. Forget about EBC. Do you think that DK crush is probably the optimal strategy for two-stent strategy?
It's definitely an extremely good technique, but you know, no lesion are the same. So one size doesn't fit all.
Yeah.
So you always have a choice, and that's actually the importance. But there's one thing, I was talking about the polygon of confluence, which is actually the connector of the three vessels in a bifurcation. And that area is extremely difficult to scaffold properly. And if you look into the different nidus of restenosis in all the different stent techniques, they will always be in the corners of the takeoff of the circumflex, most often in the roof, then secondly in the floor, and then in the takeoff of the LAD, and then basically at the ostium of the LM if it's the left main. But having said that, if it's properly performed, as Shao-Liang just told us, that you really use, as also Kirtane really underlined, if you really use that simultaneous last dilatation of the kissing balloons to put the carina exactly in the middle, and then do the third part, then you have that. This is the technique that is mostly capable of actually scaffolding the entire polygon of confluence. But it's complex, and you need to perform it with perfection to reach that result. The caveat is actually the 3 layers of drug-eluting material, which again is a nidus of restenosis and stent thrombosis. But actually, when you ask me if it's the optimal technique, I can't answer that, but it's the optimal technique to actually scaffold the polygon of confluence.
Yeah. All right. I mean, I know that time is short. Is there any other questions that we haven't
I think there are a lot of,
Yeah.
on the chat, in terms of the techniques, tips and tricks. I think that will probably, Kumara will try and answer as much as he can, but I think, as you know, probably you need another hour session to go to that. Okay.
But maybe I may just very, very shortly comment. I know you said that I was not mentioning the ABC, but we actually have the 16th consensus document out exactly as we are talking now. It's published simultaneously with the first day of EuroPCR, and it's about tips and tricks and pitfalls and how to solve them in all the known techniques. Yeah. You have free access to them because you're participating in the EuroPCR, so download them and refer to them.
All right. Anyway, there's going to be bifurcation, DK crush, and even all bifurcation simulation techniques on Friday, so 11:30 to 12:15, so please be there. I just want to say that I hope we have covered as much as possible for DK crush. Obviously, you know that we need more time to discuss every bit in terms of tips and tricks. I would like to thank the person, the Saiful, and also Kumara for performing the case. Amin for moderating this, Ajay and Shao-Liang for not being with us, but thank you very much. And of course, Lassen for being with us. And all of you, both audience on-site and off-site, who actually contributed to the discussion. And of course, to Medtronic for this special grant to support this meeting, session. Thank you very much and have a good day, guys.